Good evening, welcome. It's now 6 o'clock. I'm handing over to Dr. Hinki Godana. Dr. Godana, over to you.
Thank you very much, Remy. Welcome, colleagues, to another exciting webinar brought to you by SAMA. Thank you for joining us as we unpack the realities of managing patients with cerebral palsy alongside practical guidance on VAT and practice compliance. I am Dr. Ausin Godana, a proud GP by choice who is based in Pretoria in the Gauteng province. I am also a member of SAMA, SAMA's GPPC, which stands for GPs in Private Practice Committee, and I'm delighted to interact with you today. We welcome you to reach out to us, colleagues, if you are passionate about the profession and would actually like to contribute to the betterment of the profession and the sustainability of GP practice. We really welcome you to join us in the GPPC in advocating for GPs' rights and GP-related issues. For today, colleagues, first up, we will have a presentation on VAT. We all know that VAT has been a pain in the shoe for most healthcare professionals. What we are engaged in today is a step in the right direction to understand the ins and outs of VAT in our space. We as SAMA would like to hear how VAT actually impacts your business. And we are going to be taking up the VAT issue with relevant stakeholders. So colleagues, please complete the survey that is going to be circulated during the VAT presentation and after. We will also circulate the survey after the whole presentations, both presentations have been made, so that we can gain insights and better understand how VAT actually impacts all of us as colleagues. This will actually impact on how well we are able to engage with the relevant stakeholders going forward, because we will go forward knowing very well what are the issues that are plaguing the profession as far as VAT is concerned. So without further ado, colleagues, I'm going to introduce our first speaker. Our first speaker is Johan Rickert. I hope I'm saying it correct. Johan is the co-founder and managing director of APS Africa and a trusted advisor to healthcare professionals building sustainable, patient-centered businesses. Johan holds a master's in accounting. He has served the medical community through APS Africa since 2011. He possesses deep expertise in advanced strategy, group structuring, and practice growth. Johan is a seasoned business advisor and specializes in guiding clinicians through the transition from public to private practice and from practitioner to actually being a business owner. He is known for translating complex texts and structuring considerations into clear practical steps, helping medical professionals optimize entity structures, enhance compliance, and make informed decisions that support long-term scalability. In his presentation, Johan equips attendees with actionable strategies to navigate the shift from practice to business, design efficient and compliant business structures, and manage tax-related challenges that are specific to the medical industry. Johan, welcome, and over to you.
Thank you very much, Doc. That was quite a big introduction. I must probably ask people to shorten that. To everyone here, welcome to this presentation. I know you are all currently very excited about the fact that it is provisional tax at the end of the month. I know you're all loving the phone calls you are getting from your accountants and the emails. giving you the shock of what amount is payable. Unfortunately, for some of you, VAT is a every second month event. So today I'll just want to give you a brief overview of what value-added tax is, how it's managed, a few aspects of SARS, and hopefully it will give you a better understanding of the VAT process. Unfortunately, I have to start with a short disclaimer. Again, this is a generic presentation. One thing I did not put in here, please note any presentation by a tax accountant or a chartered accountant at 6 in the afternoon may cause drowsiness, and I take no responsibility for those of you driving at the moment. Please take note, you've been warned. So what are we going to do today? Firstly, brief overview of VAT. For those of you moving into private practice, showing the process of registration. Then I'm going to go to our friends SARS, South African Revenue Services, not the serious acute respiratory syndrome, although it does cause that when you get that bill from SARS or that final demand letter. I'm going to give you a brief overview of what's happening and how they have sharpened up their tools, talking about penalties, and then apps to mitigate and reduce your risk. Always say, with the right tools, you can minimize and eliminate any surprises. So firstly, what is VAT? I've given you the definition. It's indirect tax. The whole definition is indirect tax levied on each process of the production, blah, blah, blah. The main thing is you are acting as an agent for SARS, in effect. The payments you receive includes VAT, and SARS expect you to take that 15% and, after deducting your inputs, paying it over to them. It's not your money. Input is when you've got a situation where, let's say, you're ophthalmologist, you buy a laser machine, or you're radiologist and you buy an MRI machine. That's a big VAT input. That you can claim back, that 15%. Unfortunately, most medical practices are not input heavy. You deliver a service, so you've got your startup costs when you start your practice, but then from there on in, you are billing. Without the inputs, you receive the money, and that 15% needs to be paid over to SARS. Remember, SARS sees that as their money, and you are acting as an agent for them. So in effect, you are debt collector. So when do you need to register for SARS, and what are the steps? So firstly, you must determine if you should register for VAT. It's if your taxable supplies, that's your billings, exceeds 1 million rand in any 12-month period, or it's expected to exceed. You can also have a voluntary registration. I know this is recorded, but in any case, I don't know why anyone would voluntarily register immediately, unless you've got very high inputs, capital inputs in your practice, if you're setting up a practice. Unfortunately, it's a very, very intensive process to register for VAT. It's an e-filing process. But for those of you that have gone through it, a few years back, it was quite easy. Unfortunately, due to numerous fraud events, SARS has changed the whole process. What do they need? And this is non-negotiable. You've got an appointment with a SARS official, and this is what's needed. Your accountant can help you with this and can do it if they're the registered or the tax representative. They need the company registration documents and your ID, if you're sole proprietor, proof of your business address, bank confirmation letter, your financial statements or turnover proof. For those voluntary registrations, you need an invoice of at least 50,000 Rand, your residential address of SARS representative individual, and you may also be required to actually sit in that meeting with SARS. They've been doing it a lot more lately, and it is extremely tedious. But this is the process. So when do you need to register for VAT? Again, when your taxable supplies exceed 1 million Rand or it's expected to exceed. That's non-negotiable. So when you see your turnover is reaching 80 or 90,000 Rand a month, your billings from your billing company, you need to start looking at registering for VAT or starting the process. That is expected to exceed in a 12-month period. Again, voluntary registration. If you're putting up a practice and you've got a lot of expenses, capital expenses, equipment, etc. Apologies, seems like the webinar kicked me out on that one. I think it got bored as well. So as I said, for medical practice, Section 15 of the VAT Act limits cash-based accounting. So what does it mean with cash-based and invoice-based? I'll start with this. We see a lot of practices we take over sitting with a fact that they say, this is the amount I received from my bank account, this is the amount of VAT I should pay. Unfortunately, the default registration by SARS is invoice-based. That's for the account for when VAT and the invoices are issued, even though the patient has not paid you yet. I know it does not seem fair. We've got numerous cases where, and this is also important why you should keep up to date with your billing company and make sure that your bad or your debtor days do not exceed 30, preferably less, because you are carrying the load for that. When you bill, you have to pay the VAT whether you've received the money or not. Same with income tax. SARS says on the income tax side, it's the first of receipt or accrual. So if it's a debt in your books, even if you haven't received the money, you could have received 10 million rand billings and received 0 rand, you are still liable for the VAT on that money and the income tax. That is why your relationship with your billing company is extremely important, and your relationship with your accountant. You should manage your cash flow and do a monthly check on your debtors. Preferably, I say, do the benefit checks and make sure that the patient pays before they leave your rooms. This is the default registration. So if you register with SARS, you are on the invoice base. Cash base is for when cash is paid or received. Unfortunately, I'll go through that, but to be a cash-based business, medical practices normally do not adhere to that. So Section 50 of the VAT Act limits cash-based accounting for you. Most medical practices make taxable and exempt supplies, and SARS generally requires invoice-based. I have not found a case in the last 15 years where SARS said cash-based for medical practice. So please, invoice-based, but make sure that your accountant and your billing company keep your debtors under control. So when should I pay VAT? The VAT return schedules. Firstly, you get the monthly returns. For those of you doing more than 30 million rand turnover, you are on the monthly one. And well done, you can contact me if you need an accountant. But yeah, for most, it's only for large corporates, listed companies and exporters. Most medical practices are on the bi-monthly returns. These are SMEs, professional firms, and medical practices. So every second month you are required to submit your VAT 201 and pay VAT. It can either end on February or March, so depending, odds and evens. And I'm not going to go into the annual returns, not really applicable to you. Now to the, I always say, SARS, they've got no carrots and only sticks. But one of the first sticks they use for late VAT submissions. The Tax Administration Act, Section 210 to 212 apply. I know you're all going to read this after I've done, but please trust me, it's actually a real act. But they've got penalties there that apply monthly. Firstly, they charge interest on outstanding VAT balances. They've got the interest rates on their website. The biggest problem I have with this is if you can't pay your VAT, remember, if you have to pay penalties and interest to SARS, that penalties and interest are not tax deductible. So you incur an interest expense that you cannot deduct for tax. Talk to your financial advisor, talk to your accountant if you see you're not going to be able to make your VAT payment, and rather get a financial loan or an overdraft facility where you can still pay your VAT, but at least the interest on that you can deduct for tax purposes. So you save that 27%, or for those who are sole proprietors, 45%. Again, all interests are charged on the outstanding VAT balances. Understatement penalties can be up to 200% of the tax due. So if SARS catches you, and this is not even the worst part, if they catch you, they can charge you up to 200% of what you owe. Do the maths, it's massive amounts, and we are finding that SARS are applying this more and more. And criminal prosecution possible for intentional non-compliance. When you look at the VAT and Income Tax Act, I always say the Income Tax Act gives you, there's a bit more gray area, it's interpretation. You can get a legal opinion and say, this, I interpreted this, so I wanted to deduct this expense. You go to SARS and they'll say, we agree or we don't agree, please pay us the amount. With VAT, there's no gray areas. I always say if you jippo VAT, you can go to jail. And I've watched the movie Shawshank Redemption numerous times, and I do not think accountants or medical professionals for that matter will do well in prison. So do not jippo VAT. Why VAT reconciliations matter? This is the first part. You have to submit your VAT 201. Your VAT 201 is submitted by your accountant. They take the information, and not just from your bank account. If they only look at your bank account, there's a problem. They must also ask for your billing information for that month and combine the two to make sure that's an accurate amount. This gets submitted to SARS, and at the end of the year, your accountant should do a VAT recon. That's a summary of all the VAT returns being submitted, recalculating the revenue that was declared on the VAT 201s, and comparing that to your annual financial statements. If the revenue or your turnover on your financial statements differ from your turnover on the VAT 201s, it will trigger an automatic audit. You do not want a SARS audit. So please make sure that they got the right information and that they do VAT recons, especially before they submit. So they can't say afterwards, oh, I did not know we're going to get audited. They do this on VAT and they do this on pay as you earn as well. So be careful and make sure that VAT reconciliations are done. You don't need to know how to do it. You just need to know it has to be done, one. And two, you must ensure that the turnover on the financial statements is the same as on the VAT recon. So just ask your accountant in an email, can you please confirm that the VAT recon balances or has been done at least? With the VAT 201 submission, it can trigger an audit. So what are the supporting documents that are required? And again, I know you guys are busy, so you either have a shoebox filled with slips in your car or on the boot that you never send to anyone. There are ways, and I'll get to the apps that can help you with that. But what can they ask? They can ask for sales invoices, your billing information, your supplier, if you have any inputs, your supplier tax invoices, either Transform or whoever. And there's details on the invoices that need to be adhered to, the name of the company, VAT registration number, address, etc. They can ask for your bank statements. I'll show you something later on. They don't have to. General ledger and your VAT control account. That's done by the accountants. And import-export documentation, if it's applicable. So this needs to be ready. You don't want a situation where SARS asks you for the documents and you now have to scramble for the next 2 weeks to get everything together, submit it to SARS. You need to submit it as soon as possible. With the right tech stack, the right applications, it can be done immediately in effect. So it shouldn't be a step and should not cause you sleepless nights. This should cause you sleepless nights, unfortunately. SARS has known what's happening in bank accounts and access to bank accounts for more than 5 years. But with the application of AI, they've now ramped up, unfortunately, or fortunately, to be able to actually process what's going on in your bank accounts. And I'm not just talking about your business bank accounts. It includes that, I may not name, let's say, Capitec or a silly little account that you hide somewhere. They've got access to everything. And with this whole beneficial ownership, the FICA, RICA, and AI, they can actually combine, and they've got the ability to do that. So we are finding that they are suddenly getting queries where they say, we have picked up that there are amounts coming into this business account that does not correspond to your VAT returns. And then you need a quick explanation for why that is. It's an inheritance or XYZ, or they sold some of the equipment, but you need I think SARS stopped me just in case I give away another trade secret. But the main thing here is SARS knows what's going on in your bank accounts. So the best way of staying or tax planning is staying compliant. I've got a few scary ones here. So what's happening? SARS receives your bank data directly from the financial institutions. It's happening. They are comparing your deposits to your VAT declarations. Any discrepancies will trigger an audit and assessments. And for those of you that want to go and read the full article, MoneyWeb, SARS knows what's happening in your bank account. Scary reading. Next one is SARS Modernization 3.0. We attended a conference the other day with SARS, and they are tightening the noose. They are focusing on VAT fraud, VAT evasion, trusts. There's quite a few, and they now have the tools to actually implement what they want to do, and it is happening. So please, as soon as they are able to pick up something, you are under the microscope. So I'm going to please ask you, if you've got an account or you receive cash on one side or you deposit in another account, they will pick you up. It's a matter of time. So what are they doing with artificial intelligence? They are doing data analytics and AI, and the AI identifies VAT risks and non-compliance patterns. And it targets audits and faster assessments. They can now do it immediately and quickly. They can have a look, put it into AI, almost like I've done these slides. You put it into ChatGPT and you get something out. They are just more advanced, a lot more advanced than that. So now I've almost frightened you enough, unfortunately. And as I said, accountants, especially this one, don't want to go to jail. So this is treated as a criminal offense. Again, there's no gray areas. You can talk to me about income tax structuring. There I can make hundreds of plans and you can save a lot of money there and keep yourself at a 27% tax rate, depending on your lifestyle and what you do. That you can do. Rather than paying 45%, you can say 27%. You cannot do anything on the VAT side unless they decide to make medical professionals exempt from VAT, which would be great. But yeah, we can always hope. We'll see what the new budget speech holds for us. But yeah, 15 years imprisonment. I've got hundreds of cases here where anything from 5 years to 15 years for VAT fraud. And again, be careful what's being submitted. Remember, you as the business owner, I'm not saying practice owner, you as the business owner are responsible for what is submitted to SARS. So you are going to jail with your accountant. There's not but the accountant did it, I don't know what's going on. As the director of your business, as the owner of the business, you need to make sure that your accountant and you stay compliant. Now, I've frightened you enough. There are easy ways to manage your VAT. Firstly, I like using Xero accounting software. One, it links directly with your bank account, so you get the data directly from there into the account. It simplifies the VAT filing, so you can do MP201 directly from Xero. But the important one is there are apps that link with Xero. One is HubDoc, two is Dex. So the days of keeping that box of slips and then trying to find it years later are gone. All you do is you take a simple scan with the app. It's uploaded directly into the accounting software Xero. And I have no shares in Xero, so I'm not getting any financial benefit. I just like the ease of use and it saves time. So you can snap it. It gets immediately linked to the specific expense. And when you do have a SARS query, the accountant can just send that, let's say, X account for water and lights or for repairs and maintenance, whatever, directly to SARS. The second thing is you need to include your billing information. So your accountant needs to get your billing information at least. I know a lot of people say every 2 months. I say on a monthly basis. It needs to be checked on a monthly basis, not just for VAT, but more importantly, to see your debtor days and to determine your cash flow. You need to be able to determine what your next VAT payment will be a month before you have to pay it. It should not be a surprise. And your accountant, a business advisor, should be able to assist you with the process. The days of running a medical practice as it's been done are long gone. I always say the similarities between a medical practice and a liquor store is the fact that if I walk into a medical practice or a liquor store, a nice wine shop, I expect to feel better when I walk out. The difference is the liquor store owner knows exactly how much money he makes in every quart of beer, every bottle of wine, and he's got budgets, variance reports, and he knows how his cash flow is looking. Whereas the medical practice, most of you find have no idea. They know the money comes in, the money goes out, but there's no planning. You all must start running your practices like businesses, and your accountant should work with you in that. So Xero, it does automated VAT calculations reports. Still needs to be checked, but it's a lot more accurate, I found. It's an easy VAT 201 preparation in Recon and can get submitted directly out of Xero. I've got real-time tracking of your input and output VAT. So if a client phones, you can actually open up Xero and say, currently your VAT amount payable is this, and if I project it for the rest of the, let's say it's 20 days left in the month, you will have to pay X amount on due date. And most importantly, we're all human. In your case, it's more serious when you make mistakes than we do. But still, using technology and AI with programs like Xero Text reduces manual errors. You don't want to SARS audit because of a manual error. And it's easy for you to track. You have to get monthly reporting, see what's going on in your business, and be able to ask the right questions. Okay, this is just the ultimate tax guide. You guys are also more than welcome on the website to contact me if you want a free consultation. We will update this guide by the next budget speech is imminent now. So as soon as Enoch Gondwana has done his budget speech, we'll update it. This is just a basic fact sheet for when starting a practice, or just to quickly check what can I write off. That new MRI machine, that fancy thing I bought, over how many years can we depreciate it? The computers that I buy, XYZ. It's just a little quick reference guide that you guys can use and go through it. But please contact your accountant and start getting a relationship. You need to see your accountant on a monthly basis, or your account manager, or whoever works with you, to work and start running it like a business. It doesn't take time. It can be a 10-minute check-in, but just manage the cash flow. If your cash flow is managed correctly, suddenly the VAT payments become less of a hassle. Rather than spending the money in the account and then at the end of the month say, oh, she's now have to pay VAT, now I've got a problem. VAT becomes less of a burden if you manage your cash flow correctly. Okay, just a few things there. Okay, thank you very much. Let's stop
Wow,
sharing.
thank you very much, Johan. I'm feeling very stressed about going to jail. I thought my accountant was gonna go alone. Finding out that I'm going to, I'm shivering. Thank you, Johan, for this presentation. Colleagues, we have thank you, Johan. You've left us ample time. We have enough time, colleagues, to get into the Q&A session. Please type your questions on the chat box, and we already have some questions, Johan. Let me kick off with a question from one of our colleagues, Dr. Mgugudo Sillo. She's asking, and this is the question that a lot of us want to know. We want to know the answer to this one. Do you think, Johan, we can build a case for medical practices to be exempt from VAT? From VAT?
Yeah, this is one of those questions that I know what I want, and I know what I want to answer, and I know the reality. So from my perspective, yes. The main thing is, if you immediately remove medical practices from that, I'm not talking about cosmetic surgery. I'm talking about your ICD-10 and PMBs and stuff like that. As soon as you can remove the VAT burden from that component, because you don't have the input. Most medical professionals that deal with those cases, PMBs, etc., don't have high input costs that they can claim. As soon as you can take away that output VAT component, immediately you reduce the cost, not just for the doctor, but also for the patient by 15%. And that's a massive, massive saving to the ones that actually need to afford it. So, yes, I believe if you can do the financial modeling, I know a few people that can do that. I don't know who's going to fund it. But there is definitely a case for that, especially certain professions or certain disciplines that I would definitely recommend that be taken out of the equation, reduce the fees by 15%. And yeah, I don't want to go into the whole funding section of that, but it does make it fair on the patient side, especially.
Johan, has it been done before? Has there ever been an industry that has been VAT exempted? Like, what does this process look like? What factors should we be considering if we take that route?
That's a question I would love to answer, but unfortunately, except for the basic goods, I'll have to go and check with them. But from my side, I've never been involved in the process. I know the funders and the rest of it, how that process works, but unfortunately, I don't know how the process works to get the VAT exemption. I know there's talk about looking at exempting medical professionals and certain aspects of that, but again, the problem is currently balancing the budget. And at this point, I know they say there's no funding for NHI, there's no funding for XYZ, and we are still in a deficit. We've fortunately reached the debt ceiling. I'm not an economist, just for those wondering, but from a budget perspective, we've reached the debt ceiling. So from what I can see, the government's not going to incur any more additional debt to cover something like this. So if this should happen, it can take a year or 2, 3 years until we see a reduction in that government debt and a bit of leeway in that. But we never know. Maybe they increase the price of cigarettes and sugar cool drinks and wine again, and use that to rather fund healthcare.
Thank you, Johan. We have some questions on the Q&A, but let me finish up this discussion with the the legislative part. Johan, is there a particular reason why the 1 million mark has been there for so many years that it hasn't been raised, that you need only register when you reach 2, 3, 4 million? I mean, it's been there for as long as I've been in private practice. Is there a particular reason, and does that have an impact on anything and also on our businesses?
The short answer is yes, there's a reason. If they lift the 1 million rand, they get less VAT. So it's purely, you can find it in all the spheres of income tax and VAT. So what happens is it's like your scope or inflation creep that you used to have in your income tax, your personal income tax. There were these brackets and they would increase it every year with inflation. And what's happened in the last 5 years, they've just stopped that. The same with your deceased estate duties, where it's been 20%, 20 and 25%, depending on the value, but the value of the estate has stayed the same. Your rebates have stayed the same. Capital gains, primary residence exclusion still stayed the same. So they always say, when they do the budget this year again, you'll hear everyone say, no, it's a great budget. They haven't increased VAT. They didn't increase personal income tax, but they do. They do it in ways like this. They keep the VAT rate at 1 million rand. So every year there's inflation. Let's say our inflation is now 5%. So every year your turnover should go up by at least 5%. So that over the last 20 years, that 1 million rand should now be about 3 million rand, but it has been increased. Same with your primary rebates. So every year they keep everything the same. They don't increase any taxes, but that's why people always say, I can feel my pocket. I don't have as much money as I used to have. But the tax rate hasn't gone up. Inflation is that high. What's happening? But in effect, they are charging you, and you are paying more tax, unfortunately, every year as it goes along.
Yeah. Thank
Sneaky.
you for that, Johan. Let's get into more questions. One of our colleagues is saying, thank you very much for a very informative presentation. And they are asking for, in terms of the VAT charged on invoices, can I add VAT over and above the medical aid fee? Is there guidance on that?
No, so the fee you get, you can charge, as I say, you can raise your fees up to a point, but you still pay 15%. You can't add another 15%. You can increase your fees by 15%. Let's say you go from 100% scheme rate and say, okay, fine, no, I'm going to charge my patients 115%. You can do that. But again, there is a lot of calculations and discussions you have to do with your accountant. One, what's your demographics of your patients? And when I talk about that, what medical aid are they on the classic comprehensive, key care, or are they non-medical aid members? Can they afford a 15% increase? If you increase the fees by 15%, how many patients will go next door? So it's easy to say I'm going to increase prices to mitigate the VAT or to get more money, but it doesn't work as easy as that. It's a big. We've even had clients where we had to do market research in the area to see what would happen if we do increase prices. And we found that if we increase, there are so much competition in that area, you'll lose more than what you'll make on any increases. So yes, if I want to say, if you're in a town like I come from Lichtenburg, I used to grow up there. So if in Lichtenburg, you know your competition is about 3 GPs. That's if you raise your prices, you can maybe get away with it. But if you are like we are now in Pretoria or Johannesburg, there's so many specialists. I'm not even talking about Cape Town. If you raise your prices by 10 to 15%, you will see a drop off in patients. So be careful of that. Sometimes it works, sometimes it does.
Yeah, thank you, Johan. I want to take this question further. I think the colleague is driving at something here. When I start my practice, I get X amount from medical aid X. Let's say 500 Rand per consultation. I'm not VAT registered. Then when I reach the ceiling of 1 million and I get VAT registered, the amount that I'm receiving from the medical aid remains the same. So talk to us about that, because this is what doctor is asking. I think it's part of a question that when it comes to medical aid, can I add 15%? Because left to the medical aid, they give you the same amount, irrespective of your VAT registration. What's up with that?
Okay, so there, I normally, when we do conferences, I normally throw one part to the billing company guys, and I do the first part. So what I would suggest when you start out, you don't register for VAT. Okay, you receive your 500 Rand, you save the 15%, and it gives you time to build up a client base. So let's say in the first, depending on your specialty, GP, let's say it takes you 6 to 8 or 12 months to reach the million Rand. But by the time you reach that or get close to a million Rand, as I say, expected to reach 1 million Rand, you delay. So at that point, you've got recurring patients. You know your patients, you know their comorbidities, and you can build a business case around that in effect. Then when you register, that's the ideal time then to actually increase your prices. The main thing there is people get used to you. 15% might seem drastic, so I'd normally suggest do a 7.5% increase in the first 6 months, see how it goes, and then 6 months later, another 7.5 to get you to that 15. From a business case, I'd say when you get your patient base and you can see, okay, fine, I've got these patients, they've got these comorbidities, I can get them in twice a year to do X, Y, Z, check their blood pressure, etc. But when you do your increases, I would say increase for 15%, but don't do it in one shot. Do a 5, 5, 5 or 7.5% increase. And but first it gives you time, build up the patient base. But I agree, it is a big knock to go from 500 Rand per patient, then take a 15% knock immediately. So as soon as you register, increase prices, and most patients understand.
Okay, let me move to the next question. Thanks, Johan. There's a question, can you get SARS compromise if you are in areas? Can you get a compromise from SARS if you are in areas? Oh, Renier, I think we've lost Johan. Maybe he'll be back soon. So let me freestyle a bit. Colleagues, I didn't want to while Johan is off, let's scanner a bit. I didn't want to go deep into that issue of medical aid, but maybe if we have time at the end, we can. But I think one issue that irks a lot of us, oh yeah, Johan is back while we were scannering.
Yeah.
Johan, we were scannering that, you know, one of our biggest frustrations with medical aid is that if I am on a network of a certain medical aid and they are paying 500 Rand per consultation, they pay 500 Rand irrespective of your VAT registration. And that is killing us because you can't, even when you get VAT registered, you cannot move your price. You can move your price all you want, but they will still pay you what they pay,
Yeah.
which is 500.
You have to collect the balance from the patient, yes.
Yes. So yeah, it's a big frustration, Johan, and we don't always understand why is it that when we become VAT registered, medical aids still pay us the same amount. But I know for you, Johan, in your profession, when you get VAT registered and you bill your clients, you bill them VAT 15%, and that's okay. You will be paid for your 15%.
Definitely. Yeah,
Oh.
so I don't know. The medical aids are I was going to say, I don't want to say too much, but yeah, it is interesting that they work like that, and it's frustrating. Always say it's okay for, if you look at certain specialists and your cosmetics and ophthalmologists, etc., that's a different, but for a GP to take a 15% knock is a massive difference in the annual turnover. So yeah, no, I must say it's one of those things I don't always understand, and unfortunately, I wish I had the power to change something like that. But yeah, I think something like a VAT exemption would be a good start. Even if you can just do it for the basic, as I said, something like the 500 for GP visit. If you can exclude that, that will make it a lot more affordable for everyone through the medical profession.
Yep. Let me move on. I thought we had time, but it seems like colleagues are on the roll. Does an online GP consultation as a GP for cash payment EFT at a reduced rate VATable?
Yeah. If you're VAT registered, you receive the money, it includes, you can't get away. I don't want to say, yeah, you can't get away from it, unfortunately. If you're VAT registered and you bill, you have to charge VAT. That's unfortunately just how it goes.
Yeah. Thank you.
I'd say rather save on income tax. Income tax is a lot easier to make plans on and get a nice reduction. It's a lot bigger saving than the 15% on your VAT in any case.
Which leads us to the next question. A colleague is asking, how can I minimize income tax if I'm not VAT registered?
So if you're not VAT registered, that means your turnover is below 1 million. So let's say working on 800,000 Rand. So if you pay yourself just a salary with a retirement annuity and your basics, your tax rate should be around about 15 to 20%, 22%. And then you must also maximize legitimate tax deductions. We find that a lot of GP practices, they have a lot of expenses, but they don't put it all through their books. And when I say expenses, I mean legitimate expenses for tax purposes. So you can reduce that to get to a taxable income of 300,000 Rand, which is on a very, very low rate for income tax. So yeah, there are quite a few ways. I can keep you busy if you let me talk about income tax and group structuring and stuff like that. I can talk for hours, but I don't want to get the last three delegates to sleep. So
Thank you so very much, Johan. I'm good. Oh, I'm out of time. Johan,
yeah.
this has been very informative. It is raising our blood pressures somehow, but you know, we still need to know about VAT, and we need to stay compliant for as long as the situation is as it is. So thank you very much, Johan. Are you going to stay with us till the end in case we have some extra questions, or are you gonna leave us?
I'm going to pop out for 15 minutes. I know I look old, but I've got a 1-year-old daughter. So I'll quickly help my wife put her to bed and I'll pop back in. So I just need 15 minutes.
Thank you very much, Johan. Much appreciated. If we can still
Thank
have
you,
you
Doc.
for a few more minutes towards the end, who knows, we might have time to just put in a few more questions. Thank you so much, Johan. It's been very illuminating. Thank you.
No, thank you very much. Have a good evening.
Thank you. Thank you. Colleagues, we are... Oh, no, I let Johan go early. Johan, come back. Johan, come in, Johan.
Yes.
Oh, Johan, we still have 10 minutes. I'm so sorry, Johan. I'm so sorry. We can't let you go. We still have questions. We have 10 more minutes. Then after these 10 minutes, Johan, then you can go like
Okay,
for the
then
rest
I'm
of
out.
it.
Then I'm out. No problem.
Okay, all right. So back to it, Johan. There's a question about whether let me just read it as is. The question is whether there is justification for the medical aids escaping the transition. I'm hoping you get it, Johan. I'm not quite clear, but I think
I'm not.
You also are
I'm
not.
also not. Yeah, no, not 100%. Yeah, no, unfortunately, the transition out of that, I don't know. No,
Okay.
unfortunately.
I thought maybe it was accounting speak that I don't know, but let me move to the next one for now. Maybe we'll clarify that in a moment. The other question is, do we know what proportion of the VAT budget is from medical practice? I suppose maybe from the healthcare industry. What proportion?
I'll have to actually just take a guess, but it is in proportion to the rest. We do have an economist that we work with that can actually tell me this. I can find out, but our biggest contributors are actually more the bigger industries like mining, etc. They are the biggest contributors. Medical professionals, I'll have to have a look. I unfortunately don't know that number, but I'll see when the budget comes out. I'll have a look this year to see what proportion does come out. That will actually be quite interesting.
Right. So, Johan, another question is on that exemption. We want it. One of the colleagues is asking, how can we motivate for the VAT exemption?
I think the first thing that needs to be done is to build an economic case. That's the biggest thing. So we know government wants to make healthcare more open for all South Africans, especially with the NHI. If you can build a case where you can show that if you can reduce a GP visit by 15%, how much more accessible will it be for a patient to come in, and then also reduce the cost for the government on implementing the NHI. You'll find that as soon as you reduce that VAT rate, you'll find a lot more GPs that are sitting at home at this point will be willing to actually start and open up a practice, because suddenly it becomes a bit more economical viable. And from what we've seen is we need more medical professionals in the rural areas. And I'm not, if you just look, most of them want to work in Johannesburg, Victoria, but there's a big need there. And if you can reduce that VAT rate, you can actually make it economically viable for a medical professional to open up a practice because immediately they get 15% more in their pockets, and they can serve the community. As I say, it's much more lucrative to see X amount. GPs must do what, 3.25 patients per hour. So if they can stick to that and get full 500 Rand, it will be great.
Thank you very much for that, Johan. Dr. Mlisana, could you please clarify that the question you just posed? You can unmute and pose the question directly.
Thank you very much. That's fine. Johan, the transition just means the point at which the doctor reaches the income threshold at which they must start submitting VAT. So my argument is that the actual tax collector should be the medical aid.
Oh, okay, I understand the question. So no, I understand what you're meaning. The only problem with that is all that the medical aid will do is if you lump them with the burden, and I'm talking freely now I'm being recorded, but one, they'll deduct the 15% and only pay you the 400 something Rand in your account. And if you're lucky, they'll also add an admin fee for doing the VAT on your behalf. Just kidding. But that's in effect what will happen, unfortunately. So they can do the administration on their side, but the other problem is you'll still get the same amount in your pocket. The big thing about VAT is you need to either get medical professionals exempt. Secondly, you need to manage the cash flow in the business because, as I've said now a few times, the biggest problem we find with that is doctors, except for from 500,000 Rand, 1 million Rand, if you get your consultation fees, that's a big problem. But with anyone earning more than that, the biggest problem with that is it's not planned, and the debtors catch you at the end of the day. But yeah, unfortunately, the medical aids won't take the 15% block on your behalf, or they will just pay you less the VAT amount that they have to pay over. It's almost like dividend tax. So yeah, good question. I wish I had a better answer for you, but yeah, no, you won't get more.
Yeah. Thank you, Johan. The next one, we still have 3 minutes. We are milking it for all of you. Please give examples of input tax that we can claim.
Okay, there's quite a few. All medical equipment. If you're renting a practice, if your premises and that's VATable. If you buy vehicles, not sedans, I always say buy a cab and a half or a single cab bucky if you have to. Yeah, so it's a long list. So if you contact me, I can actually you've got my details. I can actually get our VAT department to send through a whole list, but it's quite a lot. Just get the requirements right. I always say with input tax, I don't know how to generalize it, but it's from your cell phone account. It must be in the business name, that input VAT. Entertainment's excluded, for example. Equipment's included, if you purchase that. Consumables included. Your transform accounts, depending on what you're buying. So a lot of stuff is actually included and will reduce your VAT burden. But it needs to be accounted for. You need to have the right documentation for that. But it's a massively long list. Unfortunately, the big things are capital in nature. That's the big ones. But yeah, there's a long list of inputs you can claim. And we do find that a lot of people don't claim everything that they actually can within the law. We also find a lot of people that claim a lot of things that they can't, but that's another discussion.
Thank you, Johan. You are leading us to the last question. How can we reach Johan?
Okay, yeah, it's quite easy. I'll quickly, let me just share that presentation again. When they open up the presentation, or I'll just open up the Q&A again. I don't know if you can see that. Let's just open up this one. Yeah, so they can just scan that QR code. Once you go to the website, you'll see There's also a Calendly link for me where they can make a booking for anything 15 minutes, 30 minutes. But yeah, they can just go on there. It's aps-africa.com.
Awesome, awesome.
Yeah.
Thank you very much, Johan. And apologies for letting you go and calling you back in, but you know, I couldn't let you go for that extra 2 minutes.
No problem.
Okay. Thank you so much, Johan.
Thank
This
you,
has been absolutely informative, and thank you for bringing it down to our level, because a lot of us haven't had any business-related training, but you brought it to a level we can understand, and I'm sure that colleagues will certainly be reaching out to you just to clarify some of the issues we might not have time to clarify. Thanks, Johan. Enjoy the rest of your evening.
Thanks, Doc. Have a great evening. Bye-bye.
Thank you. Bye. Colleagues, we are moving on to the next presentation on cerebral palsy. Our speaker is Dr. Zolile Mlisana. Dr. Mlisana describes himself as a transdisciplinary pediatrician whose experience has spanned equal lengths of time in both the public and private sectors. He has established pediatric departments in both private and public hospitals and has worked at all levels from district through to regional and tertiary centers. Perinatal care and maternal child health are his main focus and passion. He's also been involved in institutional governance, spanning university leadership, culminating in being principal of Medunsa. Dr. Mlisana is now registered for a doctorate in social psychology, looking at relational proximities and abuse of power. Dr. Mlisana is also a multivocational pediatrician whose social leadership spans being an athletic pastor, an executive coach, and mentor. His ever-growing passion for ethics has been tested and sharpened across a wide range of institutions and experiences. Colleagues, join me in welcoming Dr. Mlisana. Dr. Mlisana, you are welcome, and over to you.
Thanks and good evening to all colleagues. I just have a technical problem of echo on my system here. Is it doing the same on the side?
Prof, let's check.
Terrible.
Rene, are you? Rene,
Yeah,
are you
Dr. Mlisana, you don't perhaps have a cell phone also connected next to you?
I've switched off everything else.
Because we get a double audio on this side. It's like a huge echo.
Yes, that's what's happening with me too. So I'm checking I was on Bluetooth. I switched it off.
Maybe if you have another mic, you can switch to that mic.
I have switched off everything else around. What?
Dr. Godana, maybe we can give Dr. Mlisana just 2 minutes to reconnect.
I think so.
Okay, that is fine.
Yes, I was going to suggest the same, colleagues. Sorry for bulging in. Dr. Notigita here, that maybe we allow him to drop off and come back.
Okay, welcome, Dr. Notigita.
Yes.
Look, I'm
Thank you very much.
the chair here. Please, you must raise your hand.
I understand, Chair. I saw that you were having a crisis.
Yes.
I understand, Chair. Good afternoon to all the colleagues, and thanks to everybody for joining us. Thank you, Dr. Mki.
Thank you, Chair. Chair, you know, we started without you welcoming us. Would you like to welcome us maybe for a second and just let us know that the isn't just Boshiwe?
Yeah, no, I think you are doing a great job. And I must say, Dr. Nke, that I am really, really proud to be the chief executive of this association. The work that you are doing really makes me proud. And having the legend of our own, because Dr. Mlisana is, in fact, the former chair of the association. His name appears in our house in Pretoria. So welcome, former chairperson. They used to call them presidents at that time. So thank you to you and to the colleagues for joining. Thank you very much.
Thank you very much, CEO. Dr. Mlisana, let's hear if you are sorted.
Thanks, colleagues. Let's test it. It's still doing the same thing, I know.
Dr. Mlisana, it's actually doing the same thing.
Yes, it is.
Shall we try to reconnect again? Renier, would you be able maybe to off the chat, just see if you can assist?
Yeah, I don't think that's going to solve the problem. It seems with there's a problem with the mic. Maybe Dr. Mlisana can join on his cell phone and see the camera is searching for him now.
No, I just think away my Bluetooth.
Dr. Mlisana, I think if you can, maybe you can connect on your cell phone. Maybe we can hear you that way, because I think the sound lies on your laptop.
Maybe that'll take a second because I've got to set it up again. It was off.
I was going to suggest, Chair, through you, that maybe we look at changing the device and have the slides being run from our side, and we just use voice for the former chairperson.
Thank you, CEO. I agree with that suggestion. Let's give Dr. Mlisana an opportunity to just reconnect on another device. We do have his slides. I think Renier can assist to project them, and then we can proceed.
Dr. Godona?
Oh, yes, Yanda has his slides, yes.
I've got the slides, yes, thank you.
All right.
Through you, Chairperson, is it possible, I mean, Dr. Mlisana, we could hear him clearly when his camera was off. I wonder if he can try, because when he asked the question, he was clear. And then I've got the slides on my side so I can project.
Okay.
100%. I was going there.
He's gone off now, but let's see what happens when he comes on. Oh.
Thank you, Chairperson.
Okay. All right. So, colleagues, we have a bit of a reprieve, a bit of a break. Well, what to do? Shall we vent? Okay. I'll start. So, colleagues, the issue of VAT is not new, ne? And it bothers me big time. Because when I started, I knew nothing about the impact it would have on my practice. But as time went on and I realized that I'm reaching the 1 million rand mark, it hit me right in the face that I'm going to lose 15%. I know that maybe for other colleagues, like specialists who have big machines, this might not be a big deal because they have equipment and all other consumables that they are using. But as a GP, and if you are not dispensing, which I am not dispensing, it really does hit quite hard. I am pleased, though, colleagues, to say that it is not something that SAMA is sleeping on. We are really wanting to do, to start the conversation going. I had Mr. Rickert saying maybe in the budget there will be an exemption, but it truly is something that we would welcome. Oh, okay, my slot is over. Dr. Mlisana is back. If we break again, we'll bend some more. Dr. Mlisana, over to you.
All right, I hope it works well now.
Oh, yes, you sound perfect. Zianda, can you show the slides?
Okay, I think if you can please do that then, because I'm just working from my cell phone now, so it's a bit clumsy. Something
Awesome.
went wrong with the laptop. I'll rely on her to just get cues from me then when we get going. Thank you very much. Who did you say is projecting?
Zianda is projecting, Dr. Sello.
Thanks,
Yes.
Zianda, just so that I can address by name. Okay. Let's
Are
get
you able
started,
to see
Zianda,
the
then.
slides, Doc? I'm just going to put them on presentation mode.
Presentation mode is fine because, yeah, presentation mode is fine. Just give us full screen.
All right. Just confirm once you see it.
That's it. Perfect. Thank you. That's our first slide. Thank you, colleagues. And sorry about the glitch. Let me do my best then to be efficient with time. But I'll try not to rush myself so that I do this thoroughly. Firstly, if anybody may have been betrayed by the advert in terms of emphasizing on focusing on cerebral palsy, I promise you, you'll still benefit. The focus is not on her cerebral palsy, but it is actually using cerebral palsy, a case of cerebral palsy, as the pivot point or the lens through which I'm looking at the healthcare system. And this is the case of a child, which I'll unpack a little bit later, who's got cerebral palsy from 3 months of age in a hospital setting incident, and has therefore been roving through the parents, through many clinicians, and also between the two healthcare systems, private and public. And it really illustrates a lot of, or raises a lot of ethical issues, and then also highlights some ethical interventions that made a difference for this child and for this family. I'm doing this presentation in the backdrop. In fact, it was born during my preparation for a conference in Spain on a theory that I'm putting on the table academically around the phenomenon of abuse of power, which is the grip of our country at political, socio-political level. Abuse of power causing a change of the psyche on the nation, and we'll talk about that later. But the focus now is the change of psyche in healthcare practice. You may then give me the next slide. So the case is a litmus test for us to look at two things for the purposes of this particular presentation, which I've chosen. One is how, as professionals, we fail on multidisciplinary team collaboration, just generally in our practice, for reasons that we all know. I doubt I'll be raising anything that we all do not see and experience and evidence, but I'm putting them in the context of how we relent and get used to what is abnormal around us. And then the second level then is the disjuncture between private and public, insofar as continuity of care is concerned. I hope I'll remember to bring out all the details as we continue. You may please give me the next one then. It looks like this one is animated. Just go once and twice. I think I'll get the parts I want. And the next, yeah, just stop there. I think I'll just have to screen, my slides are loaded, so I don't want to animate them. I think hopefully this is the only one that's animated. So the phenomenon or the construct I've created out of the phenomenon of abuse of power is how our psyche mutates and accept what should not be accepted This is happening in healthcare, and I'm specifically looking at commercialization of health and causing a drift in our ability to care, perhaps not in the ability, but in our energies to care. And psychomutation, just briefly then, is our silent and steady normalization of things abnormal from individual level across institutions and deep into civilizational cultures. We'll talk about that later if we've got time. I think the sharing of my background is dealt with already, so I don't have to go to that side of the slide. We may go to the next slide, and perhaps we can just go back. Let me take that bottom line of that slide. In healthcare, then, psychomutation is manifesting itself as our gradual accommodation of structural distortions when the systems are strained. And there's dehiscence and the center doesn't hold. So, and I'm talking about the psychomutation within the profession or the service providers as a collective. And I'm not talking about individuals at this point in time, but our collective failure to rectify systems that are collapsing. Dr. Not Digita and I, if I call him Dix later on, I'll be referring to him. Dix and I come from the Eastern Cape, and there's an article that I saw just in the late afternoon on issues that he and I were at the center of in the Eastern Cape in terms of cerebral palsy and litigation. And it's a national issue that we know is a burden on the fiscus and on the healthcare budget. You may move on to the next slide then. I think this slide is just a repetition, quite frankly, but maybe more specifically now, this child had a lot of complications, one of which is pseudobulbar palsy, which causes certain complications that I'll speak to a little bit later. And the focus of this presentation then is around severe multidisciplinary complications in the child, multi-system complications in the child, and complexity around that in the continuity of care. Please give me the next one, Zen. This slide sort of summarizes the whole case, so I might spend a little time on it, but I encourage colleagues to throw their eye around because I'm just going to skim over, but I'll try my best to give you the best. This child at 3 months of age, having been born a normal birth, no issues, presented with respiratory distress and to the pediatric ward, and within an hour of being admitted, had a cardiorespiratory arrest, and subsequent to that, had a long stay in ICU, ventilated for 3 months, and ultimately coming out with cerebral palsy and epilepsy and multi-system complications. The child has had recurrent aspirations and repeated long ICU admissions, severe growth faltering. At 6 years, he was weighing 9 kg. I think there's an error there, omitted. It might show up later on. He now lives with a permanent tracheostomy and a permanent feeding gastrostomy. One of the critical ethical issues was the roaming between private and public out of desperation, and perhaps related in some way to some of the things that came out indirectly from Johan's presentation as pressures on ourselves as practitioners. At the moment, we're providing professional home-based care, and the child now moves between home and ICU because PEDS wards could not cope with managing him at this stage. You may give me the next one then. So a little bit of detail then, I think I may have nibbled at it already, is that the child was born in 2019. I think it was in October, and was in the wards in January of the following year, 2020, at 3 months. Admitted, according to the mother, who knows very, very clearly, she's a school teacher, very sharp, and was alert to everything going on. Brought to the hospital by ambulance, but the child was very distressed, according to her, but the sets were normal.
I established this because then I wanted to know if anything had been done for the patient en route. When they got to the hospital, the child was comfortable enough to be in the ward for 1 hour before the pediatrician was called. But within that 1 hour period, the child had a cardiorespiratory arrest. Transferred to ICU even before intubation was done, which just left a question in my mind whether the ward was not equipped to do an intubation or there was no available staff to do the intubation. And if one imagines pediatric wards are not generally close to the ICU, the transfer of that child from the ward to the ICU without being intubated when there's a cardiorespiratory arrest leaves a lot of clinical gap in my ability to account of what was happening. And I'll explain that a little bit later. Child was on IPPV1, ventilated for 3 months, and then was in high care for a further 2 months. So this baby was in the hospital for 5 months in one string. Discharged at 9 months, then thereafter coming out with cerebral palsy, spastic cerebral palsy, and epilepsy already started on treatment. Another ethical issue was the fact that I went to all the hospitals where the child had been, and I was not provided with any clinical notes. Now, in this digital age, one shouldn't have to even be driving to facilities to obtain notes, clinical notes. They should be digitized and available. So that's another deep ethical issue that compromises the patient. The child's history subsequent to that then was recurrent aspirations and some ICU admissions. I think my first consult with the child, number 6, was in October of 2022. The child was now 3 years old, just around the 3rd birthday. At that stage, the child had severe growth faltering, severe opisthotonus, and cortical blindness, which had not been on record before or couldn't make out from any sources of information I could lay my hands on, and the child had severe pseudobulbar palsy. At the time when I was seeing the patient, the family were very distraught, and they had actually, quite frankly, relented on their own efforts to support the child. They pretty much had been exhausted in their capacity and ability to look after the child, hence the severe growth faltering, which also had to do with the fact that the child had dysphagia, both from the pseudobulbar palsy and from the severe opisthotonus. The child, I think when I saw the child at the time, there was already a feeding peg, but there was a problem with that, and there was no collateral support at all to the family. The public-private drifts also were not without severe cost and toll to the family's energies. And the parents and the whole family actually stressed that what was getting them even more distraught beyond the condition of the child was that they had no clinical clarity around what was going on. There was not enough explanation and support in terms of insight for them to understand what they were up against and what had actually happened even from the outset. So the family was already tired when I met them, and I was praying that they don't again roam about and disappear. They did disappear, I think, for about 6 months. I lost them to follow up. I try to keep track of kids like this by making sure that my PA phones them, and I let them have my direct number so that even from their side, they've got direct access to me. And I hadn't seen them for 9 months before the previous time I saw them. What I had also noticed from the parents' account and also from indirectly from speaking to the colleagues who had been seeing the child, I was the 5th pediatrician to see this child in the same town. And he had been seen by a neurologist as well. No indictment on colleagues, but I couldn't get any written reports on what had happened. And I don't remember one of them even remembering who the child was in their memory. We deal with a lot of patients. It's difficult to remember every patient we deal with, but I would have thought this one could have been a case not to be forgotten. So my assessment was that there was also physician compassion fatigue. I think I'll raise the point a little bit later also that even between colleagues, we don't communicate enough between ourselves about patients that roam between us. I had been in private practice 50% of my time, then went to public, and I got spoiled by a view of both sides. When I was in public, I was always head of the team. I never did a round without the team, except when I'm just hopping around to check on patients myself. But my formal rounds included even the operational manager of every unit I was working on, because I told her when I wasn't around, she would have to take the place of being the de facto pediatrician in running the. So when I came to private, I found that being an independent practitioner means actually isolated practice. Colleagues just run in parallel. I find that very, very unhelpful to the patients. Then the last point here is just a disconnect in the whole healthcare system, which compromises sharing of information, continuity of care, and continuity of support to a family that is distraught. Please give me the next slide. I think this is the last on the clinical concept, and then we're going to look at the ethical issues, but I'm sure that colleagues already have flagged certain ethical issues as I'm narrating, and I will just highlight a few just to kickstart conversation. So from the time that I saw the child, and we've been doing well. The last admission was last year in August, and the child was again in ICU for 3 months. I think I need to speak to that. That's the time the child came in at 9 kg, being 6 years. He celebrated his 6-year birthday in the ward in the ICU. He came in weighing 9 months after 9 kgs. After 3 months, he was weighing 4.5 with very, very good nutritional resuscitation, where I had a full multidisciplinary team around him. And we made sure that we tried to do even a virtual ward round in discussing every detail about the child. His hematology and biochemistry were normal. He was stable from the point of his seizures. He stayed the 3 months because of aspiration pneumonia. Multi-system complications, I think I've mentioned that already. He had cortical blindness, and we examined, and ophthalmologists didn't find any. I didn't find anything. They confirmed that there was nothing. It was all cortical blindness. It is at this time that we insected the trachea, but the peg had been there for the previous 3 years, 2 years and a bit. This time, in discussing with the ENT and the orthopedic surgeon, we agreed that this child needed a permanent trachea because there was no structural deformity, but the spasm was very severe. Physiotherapists were there, OTs were there, everybody was around this patient, and we ultimately agreed as a multidisciplinary team that trachea was the one way to go. The navigation between the public and the private was a sad story because it was given to me that they were self-referring. There were no clear referral notes that were in operation at that time, and they also in between were stranded for funding, and so they would self-refer also on that basis. But they were lost in terms of how they kept stressing this, that we haven't been told how to look after the child at home, what to monitor for and what to know to run to the doctor for. We're just given routine monthly visits and we're not coping financially. What was very positive in the last admission that we made, I think I'll go a little bit into detail about this one, is that at the end of that 3 months when I was discharging the child, The hospital bill was 1,300,000, and about 380,000 had to be from their pocket. On the day of discharge, it just so happened that Dad, who's a traveling worker, happened to be around town, and I had the privilege of sitting down with them, as I had done before, now to talk about the finances, when because I just took it upon myself to go and find out what it cost them and whether the medical aid was going to cover, which is when I discovered that they had to pay just a little more than a third of what was due to the hospital. But then the first miracle was that the dad was around. The second one was that the hospital manager was available. So I walked straight from ICU to the hospital manager to plead a case. Firstly, on the basis of the history of this child. Secondly, on the basis of anticipated prognosis. And thirdly, on a decision I had made that the child, when they get sick, must go straight to ICU and not the pediatric ward, because the last time when I was discharging, in the same long admission, the child home and stepping down to PEDS, the child had a crisis in PEDS, a complex case which an ordinary PEDS ward, quite frankly, cannot cope with. And I knew it, but I was crossing my fingers. And then I could see that there was stress on the staff. And of course, they didn't cope. And the child had a problem. We were back in ICU, which extended it then to the 3 months. So I had this to present to the clinical manager. Up to that point, the hospital's communication with me only was on how long I'm going to keep the child, what my basis for keeping the child was. And I was speaking to case managers, and they were just doing their technical job. So this time, by God's grace, when parents were there together and I was ready to discharge home, I had already spoken to the medical aid to arrange home-based care that is professional, and they had agreed. So I spoke to the hospital manager who was available, sat down with him, and this guy didn't take a minute to say, Dr. Mlisana, we will write this account off. Then I made a second request to him, and I said, look, the parents happen to be here. I don't want to tell them that myself. Can I bring them to you so that you can tell them? And I left them in his office because I had a very rushed morning that morning. But the long and short of this particular part of the story is that that little effort, I don't even want to call it bold, because I didn't recall my boldness in doing this. I just called on my compassion and my multilateral intelligence of going beyond just thinking about the stethoscope and just being a human being supporting other human beings. You may give me the next slide, please. Perhaps just go back. I think let me finish off that part about clinician house calls. In arranging for the medical aid to get professional support at home for this child, and telling them very, very, very clearly that it's going to be a long haul. It's not something they're going to do for a week or two. So they must be prepared that it's going to be a long-term support. They actually agreed to provide a staff nurse who was going to swap calls with a lower level trained person. I think it's a caregiver who's specifically trained to look after kids like this. So this child has got 24-hour cover professional service at home. My promise to them then was that I'll be the doctor on call. They can call me anytime and I'll do my regulars, which I do every week, and I don't charge them because it won't make any difference to my financial welfare as a start. And secondly, it will ease their burden. And really, honestly, it costs me only fuel to get there and a little bit of time. But accepting only that on my first visit, I got lost, and I ended up, not because I got lost, but it was in the night, it was raining. and I ended up in a crash. So they felt very guilty about the damage to my car, which was bad. But I kept telling them that they didn't invite me to come home. I offered to come home, so I took full responsibility for the accident. You may please move to the next one. So then, colleagues, I would like to just stimulate some discussion around what I call ethical stresses. In my own mental model, this is what I've got, and there is much more. There are drivers and sub-drivers underneath, many layers. But I thought I'll pick up on these just so that I can stimulate our discussion points around the tensions on ethical issues. The first one, which I put at 6 o'clock and the bottom, it strikes me the most is the disconnect between public and private. I don't have to tell you, colleagues, you know what I'm talking about, but that compromises the patient. And the toll is very, very high. And then the second one I would like to highlight is 3 o'clock and 9 o'clock. The conversation we had with Johan just now, when I was mentioning the issue of the funders always absolving themselves of any pressures that emanate while we care after our patients, frustrate all healthcare practitioners, not just doctors. All healthcare practitioners are caught in that ethical stressor of funders doing business and not really showing care. This is why when the funders were able to accept my motivation with them without a blink, I was more than blessed. As a matter of fact, when I went to this particular medical scheme, I went as a stranger, unannounced, and I looked for whoever might be senior. And I spoke to this guy before he knew what I was about. He was polite, he was kind, and I spent an hour with him. And at the end of it, he says to me, Dr. Mlisana, you may not remember me as a little boy in Lamontville. You're not from Lamontville. I know you very well. I know your brother. We grew up together. We were little boys. And it's my privilege to help this patient around the fact that I know you, I know your credentials, I know your integrity. That was very affirming for me and motivating that I would like to share it with other colleagues to connect with community, connect with people, be human like other humans, because these connections will elevate our efficiency beyond what we can imagine. The rest of them, I think, firstly, I want to highlight the orange. Family is lost in the maze in between all of this. Firstly, they've got to contend with the funders. And I thank God that with this intervention, the funders were not a problem at all. If I could actually also put facility there, because facility also is the cost factor for the family and inconvenience factor also in many ways. And then the other one is family and ourselves, colleagues. We still fail, in my view. And allow me, colleagues, to say this. I see us failing us more as we get younger and younger. I think on the timescale of civilization, the commercialization of medicine, of healthcare, is compromising the integrity of the generation of our children. Because they enter into medicine, they enter into professional spaces, being taught to be business people, just like Johan said. But there's a good side to it, but there's a terrible side where now being business-minded overtakes our compassion. I say that with absolute respect of reality, but it is a fact. So I would encourage the younger generation to be bold enough in your age, in your real-time realities, to be a cut above the rest and do a little bit more than your colleagues do. Dix, please, when we get to discussion, let's not talk about Samatu and the laborization of our profession. I don't want that to come into this conversation. But again, this democratic rights issue is a serious ethical question. in terms of patient care. And then colleagues, softer ones, but also very, 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 very serious, is even between pediatricians and pediatricians. This patient roamed between 5 pediatricians, and 5 pediatricians don't even discuss the case. They move on with other patients. This is not acceptable in my view. It shouldn't be happening. Colleagues should be sharing information about patients to support each other to give the patients the best. And then we doctors have got the cheek to take lightly the role of the allied healthcare professionals. They've got a very, very serious role to play. And cerebral palsy brings that out very, very seriously. And our failure to make multidisciplinary team approach, take it seriously, compromises patients. So colleagues, I'm throwing this in and I'll stop right there. Perhaps I just go to those 4. At the top left, I'm talking about independent practice becoming isolated practice. This is ridiculous. This is psychomutation. Just because we're independent practitioners, we should not isolate ourselves from one another for the sake of the patient. And then I talk of holistic healthcare instead of transactional healthcare. Transactional healthcare is worried about how many patients I'm seeing today and how much money I'm making, and they mustn't walk out of my door if they're not going to pay. I think I remember Johan saying, make sure that your patients are paid by the time they leave the door. Guys, I'm a pediatrician for, how many years now? Should I count? 1989 to now, that's about, okay, you got the count. And I can see that we are really, really just going down the slide in terms of compassion, because we are pressured for survival, financial in particular. So then across the diagonally between these, then it's the independent isolated care on the one side, and it's the multidisciplinary approach. Every independent practitioner should make themselves a part of that multidisciplinary team and not just hand over and never look back when we deal with patients. And diagonally across, left top, or rather right top to bottom left, is the comparison I'm making between holistic care and transactional care. Please then give me the next slide. Now, this slide is very busy. I tried then, this is all taken from this particular patient, and colleagues, because I've been around, it's also taken from a lot of other experience I've had with a lot of other patients in very, very different settings. So without running through the slide, I just want to take the first column in terms of ethical areas. There's no limit to ethical areas, but I highlighted the few that I think 4 or 5 or 6 that I've got here. Continuity of care clinically, records and informatics. Again, I spoke to that in the narration of the case presentation. Then funding and access, professional distress, which must not be taken lightly, because we are the advocates, we are the center service agents for the patients, so our own well-being is important. Burden on the family. And then ultimately, that bottom left corner is really the intention of this conversation. Our agency as the central clinicians in any patient's care has to be driven by some level of integrity inside of us, some level of compassion inside of us, intrinsic, something that hopefully your mother and your dad taught, something hopefully that your community taught you, hopefully something that we as political parties would have taught you, as churches, at whatever sphere of influence that was surrounding you. Hopefully something we have put inside you that gives you absolute ownership of the boundaries of your integrity and compassion, and they don't get compressed circumstantially by a rotten system of health or anything else around you, where you don't compromise who you are insofar as it affects the next person just because you are choking in the situation that should be empowering you. You then become the critical advocate for that patient at that time, and that must never be surrendered. Really, that left bottom corner is the emphasis of this whole presentation. The case is just an excuse to raise the points that I'm raising. The slide is busy, so I don't even want to speak to these. And Zianda, I hope people will have this presentation so that you are welcome to interact with me even as individuals. I'll make the time outside of this conversation. This is new work. This is old work compacted as a new presentation, but it's not something that is from your textbook, your medical school textbook. You're not going to find it anywhere. It's something that actually each one of us should be able to have as sort of an audit map for ethics as we continue to do practice wherever we are. I'll skip to the next slide. We can come back then if anything caught anybody's eye, we can come back later. Then the next thing I want to focus on, the last previous slide then was mostly looking at the fatigue of the caregivers, really, and all the other issues I raised were just to accompany that. But at the center is who we are, what we are, and what we're capable of and not capable of. And then family fatigue then is the next one I want to speak to on the following slide. You may move on then. I hope we're still doing well for time. I'm not looking at the time. Dix?
We are good, Doc. We have at least 10 more minutes on this presentation, then we'll have to wrap.
I don't need it for myself. I probably will just do 3 minutes now and be done. This slide then speaks the heart of the family that I was dealing with here. I just gave them 5 questions and I said, please give me some feedback on your experience in your journey. This slide, I think I will read a little bit. The first question was, how much support from the hospital or everybody around you in the care of the child did you get? This is directly from their text. I did not edit at all. No, or rather nothing to minimal support was given. Was given based on the bill. Fees were and still are endured solely by me as the primary caregiver, as mother. Doctors, nurses, healthcare providers, how much support did you get? Most doctors didn't clearly narrate the home care part of the baby. Quite frankly, there was no home care, supported home care. They were just, they were just released to go home with the child. That's what she means, what she means there, how we were going to care for the child at home. And all that we were given is about hospital visits and visits to them. And they told me that the occupational therapists and physios were also not directly linked to them. Colleagues, it's number 3, the transfers to public, we referred to them, but I want to focus on what she has to say, what they have to say through her. Monthly visits were too costly and medical aid didn't cover all the costs. Hence we're down, referred to some hospital to continue therapy there, which was a total mess and a waste of time. A sad reflection on the transition number 1, or rather the transfer number 1, the transition number 2, and the receiving public sector facility on the other. Sad indictment. On the 4th question, assessing family fatigue and getting support for that, no formal help at all, and no formal support given to us as parents, no counseling or any other service was given. Then the last one, did you and his dad get any counseling? Okay, a bit of mix here. Or the emphasis here was, if you feel any stronger now, what has changed to make it so? She mentioned 2 things. I cut out the other one because it was, it was a bit, I cut out the other part, I'll explain later. Acceptance of my child's condition has helped me to move on. Now, the question I had was why she would have struggled with acceptance before. She made it very clear that they struggled because they had a sense of hope and nobody was saying, let me just bring out the part I smothered out there. Nobody has told us, like you have very frankly and boldly, that this is going to be a long haul. It's going to exhaust us. It's going to exhaust the funds. It's going to exhaust the healthcare givers. Nobody has helped us to come to terms with that. And then her last line, which is why I was hiding this, they said the biggest step we have taken in the life of this child was to change to a doctor who cares about everything about us. Please then give me the next slide, which hopefully is the last one. I hope you haven't fallen asleep, Zianda, or gone to
We are
the
here,
bed.
Doc. We are following.
The last slide, please. No, there's a slide missing.
Sorry, Doc, even the slide was caught by that very emotional and quite a deep reflection there.
Okay, tell the slide, I understand.
I'm just going to
It's
share
okay,
the
take your
last
time.
one.
Take your time, yeah. I think there's just one, or I think
There you
there's, yeah. Why does it look like we still have got more? So show me the sidebar, please, so that I don't.
There you go.
No, go back. Please go back. Please, I think there's a slide we skipped. Please go back. Please go back. Oh, no, we didn't. Okay, sure. All right, thank you. Thank you, sorry for not trusting you there. I think this is the penultimate, if it's not the last one. And this is the point I want to make here. I didn't make this presentation, I didn't bring this presentation about cerebral palsy. I'm using cerebral palsy and the lived experience of this family to let us look at how we manage simple cases that are complicated by the sickness of the system. All of us work under stress and all of us pray that prayer. God grant me the serenity to accept the things I cannot change, the courage to change the things I can, and the wisdom to know the difference. I just want to comment on that and encourage you to keep going with that prayer, because I do too, every day, literally, maybe every patient. The patient's lived journey here, the crisis of ethics, starts at diagnosis, goes through referrals, transitions, literal gaps in care, family fatigue, clinicians' own surrender and fatigue, and the system's disconnect. Now, the point I want to make here is going back to the definition of psychomutation, our change of psyche, because we're tolerating things we should not tolerate when we should be advocates on behalf of our patients. That serenity stops becoming serenity in accepting this. It really just becomes docility. And that's what I call psychomutation. We just give up on trying to fight and sort things that should be sorted. So let's not accept things that we can change, and let's be diligent in expanding the number of things we can change and not leave it to the politicians, leave it to SAMA. At the end of the day, you are the doctor looking after that patient. You are the professional looking after that patient. You've got advocacy that is critical, hands-on, real time, and it depends on your own internal formation and your internal integrity. And integrity is costly. And if we want to keep our integrity, my slogan is that I don't want my integrity to go to the grave before I do. In other words, it mustn't die before I die. I think this hopefully is the last slide. And then we can have some brief discussion. I indulged on some literature just to navigate some of the things, the thoughts that I
Dr. Mlisana, you were muted there at the right at the end of your sentence.
Thank you. Okay, I thought I was censured by you. I thought, yeah. I said, are you already getting rid of me now? Okay, thank you. We've got however many minutes you've got. Sorry, I'm stopping right there now.
Okay. Dr. Mlisana, thank you very much. Are you not Prof. Mlisana? Why is Prof coming to my tongue?
I think I deserve it. Keep going.
Okay. Receive it. Doc, thank you so much for a provocative and yet very motivational talk, delivered ever so gently. We heard you. And I think a lot of us are going to be really thinking hard about our roles as clinicians and what we are accepting that we shouldn't be accepting. Thank you so much for that. We do have a comment from one of the colleagues. They commented, Prof, this public-private divide is something I have thought much about as a practitioner of nearly 4 decades. My observation is that the exclusion of, private practitioners into the local public hospital, thereby denying the cross-training of younger doctors and denying the transfer of knowledge based on experience. This has evolved over the past about 25 years locally. My observation is this has been very sad for South African medicine. I share your observation and concerns. Would you like to comment, Prof?
For sure.
Prof,
I'll do that quickly. It's okay. Don't bite your tongue. It's
okay.
It makes no difference. I am currently engaging Department of Health on wastage of senior skills, and one of the generally when we think of senior skills, we think of academics and profs. In fact, I'm speaking to senior GPs where they are ahead of my time, and I'm asking them why they're not helping the local clinics, and they're wasted. So I'm speaking to government right now to talk about bridging that, what this colleague is speaking about. I would like that colleague to please contact me because I need factual information and people's voices to take forward in my conversation with government.
Thank you very much, Doc. I also have a comment on, when you spoke about clinician surrender. I think that's how you phrased it. It really touched me because I have been exposed to patients who are at the end of the journey, like stage 4 cancer of whatever organ, who have been, and I mean not disrespect, some of them have been in the public sector, and when they are discharged, there is that gap in terms of what they should be doing at home. So they end up going from GP to GP, trying to find some relief to deal with the symptoms, and also there's the family fatigue also happening at that time. I'm just wondering, Doc, if there is anything that you are doing in your work in that space. I am seeing that palliative care is not as it should be in our space.
Thank you. That's a very solid point. I'll make 2 comments on it. The first one, intervention at this level takes the core of who you are as a practitioner. That's the first tool you've got. If that tool is weak, everything else will collapse with that. So the first thing is the determination by the clinician, what I call anchor clinician, whether you're GP or specialist, anchor clinician, you then should bring everybody else around that patient the best you know how. So the first one is your own internal integrity, not moral integrity, but resilience integrity, your strength to be able to stand. And the second one then is for you to have the hope that even if we know the patient is going to go and it's going to take a long time, but there's support that can be given. I think the easy one is the illustration I have. When you've got a cardiorespiratory arrest, you've got a limited period within which to resuscitate. There's a point at which you know it's not going to help to go further. But with this kind of situation, as long as the person is breathing, there's support to be given. And so therefore, if I'm not losing the core part of your question, how does one do it? First one is your internal resilience, integrity. The second one is your ability to give your time. What I have found is that if you give time at the first bite, subsequent consultations and interactions don't take too much of your time, because you've given the family a baseline on which they're able to work on their own, and they only come to you with critical questions. So if you invest in your integrity and invest in your first moments of giving support, you have raised children, I assume, looking at you. When you raise kids, you come from work tired. All they need is to run to your car and get that hug. They don't spend even a minute and their day is made. It's like that.
Thank you very much, Doc. I see the comment section is quiet, but we do have something from the chat. In the private sector, oh yes, the question is, in the private sector, who is driving clinical governance in the private sector?
My experience coming from public into private sector, I was a square peg in a round hole. My hospital has got 5 or 6 pediatricians. When I first came, I asked what the standards are in terms of perinatal care generally, but also in terms of HIV positive patients, retroviral positive patients. And everybody looked at me, and at the end of the day, the slogan was like, I'm trying to be a head of department now in the private hospital. Who does? My short answer, I don't know. But I encourage wherever I am to make sure that that's done.
Thank you very much, Doc. We are at the end of our session. Dr. Mlisana, thank you so much. You've really given us something to chew on. We are going to, English is gone by this time. So we will digest the information and hopefully go back to what also actually brought us to medicine. Thank you so much. Colleagues, thank you so much for staying the course. There has been very little attrition, which is wonderful. It just shows the amount of interest, the ease in the topics that we had today. We heard about VAT. Some of us were stressed at some point. We could see jail facing us. But colleagues, we are empowered now with information. We know what needs to be done. Please stay compliant. We are indeed looking for opportunity, or we are, let me just say, we are advocating for exemption from VAT. But until then, please stay compliant. Me, I don't want to pursue anyone in prison. We have also heard from Dr. Mlisana really talking to us, activating our compassion, our empathy, and taking us out of that tiredness and making sure that we stick to what we came here to do as medical professionals. Colleagues, please remember that on the chat, we've been posting the survey on VAT. Please take time to complete it. I'm told it will take about 10 minutes, so we should be done with it. We are going to stay on this webinar so that those who want to complete the survey can do so while we are still on. On my side, thank you for your patience, colleagues. We hope to see you when we do the next webinar again. And Zianda, please keep them coming. We quite enjoy this engagement with colleagues on different topics. CEO, and may I recognize the chairperson is gone. In his absentia, thank you for your leadership, colleagues. We really truly feel that we are led, we are moving, and things are going at a very healthy pace. With that, colleagues, we are going to officially release our speakers and our esteemed guests. But please, for all of us who have not done the survey, please use these remaining minutes. 10 minutes beyond 8 o'clock, we will stay here to complete the survey. Till next time, colleagues, the time is 19:59, and we shall see you soon. Thank you, colleagues. Bye.
Well done. Thanks to you too.
Thank you, Prof.
Thanks.
Thanks, Dr. Elsie. Well done.
Thank you, Zianda.
Okay, I'm going to leave you guys.